metastatic breast cancer guidelines, ESO, ESMO, and ABC.
Good morning, everybody. Thank you, the organizing committee and Dr. Hisham, for this kind invitation. Conference has become a tradition. Now, when I am the last speaker in a session, I like to say that all you have heard already this morning are only appetizers. Now it's the main course. This is the main course. There was a lot of science. Now we're going to talk guidelines, what to do in the clinic on Saturday or on Monday. I will be presenting the ESO, ASCO, ESO and ESMO guidelines. We had representation from ASCO on the panel. This is the fourth guidelines meeting that we had in Lisbon in Portugal. Several of our panel members are here in the audience also. Is this moving? How do I move this, please? Oh, okay. This is the meeting that we had in Lisbon in November. ABC4 guidelines. These are the levels of evidence and grades of recommendations. These are the members of the panel, and my boss is right here, Javier, sitting over here. He is also a member of the panel. I hope I'll do a good job. I will, of course, in 15 minutes, it's hard to present everything, so I made a selection of the statements. I'll start with ER-positive, HER2-negative tumors. As a reminder, what we will be talking about are the classic anti-estrogens, the SERMs and the SERDs, tamoxifen, aromatase inhibitors, fulvestrant, and also the new targeted therapies, Cdk4 Six Inhibitors, mTOR inhibitors, PIK3CA, and others. The first statement is from ABC3. I'd like to remind everybody, endocrine therapy is the preferred option for hormone receptor positive disease, even in the presence of visceral disease. Having 2-3 nodules in the lung or 2-3 nodules in the liver does not mean you have to give chemotherapy. We define visceral crisis that requires chemotherapy when the patient has severe organ dysfunction, severe symptoms, and lab abnormalities that require immediate treatment. So just simple mets in the viscera does not mean the patient has to have chemotherapy. Now, with the guidelines, we started out tamoxifen, aromatase inhibitors. At ABC3, we said the preferred options could be aromatase inhibitor, tamoxifen, or fulvestrant. At ABC4, talking about premenopausal women, the panel agreed that if the patient declines ovarian function suppression, then tamoxifen is the only available endocrine option. And this is important, not to give aromatase inhibitors for patients who are premenopausal. Tamoxifen, although it is less effective, we should do ovarian function suppression and tamoxifen. And we had separate statements for Cdk4 Six Inhibitors. Now, this is a summary of all the data, some of the data that we had. Why do we say the options are aromatase inhibitor, tamoxifen, or fulvestrant, starting from the earlier studies in the 70s, 80s, and the first trial and Falcon trial comparing fulvestrant to aromatase inhibitors. These are the results of the Falcon trial that you have heard. Patients who do not have visceral disease, de novo metastatic breast cancer do very well with fulvestrant alone. Now, as for everolimus, the panel agreed again that the addition of everolimus to an AI is a valid option for some patients previously exposed to endocrine therapy, as it prolongs progression-free survivals, although there is no overall survival benefit. Discussing the toxicities are very important and costs with the patient as well. The panel agreed that tamoxifen or fulvestrant could be combined with everolimus. It is very important to pay attention to prevention, close monitoring, and proactive treatment of adverse event, particularly in older patients, because there is an increased toxicity in older patients. And as mentioned earlier, you may have to start with a earlier dose, but that is not in the statements. Now, these are the results of the Bolero 2 that we based the recommendations on. You have significant improvement. You have 4 or 5 months improvement when you add 5 months improvement when you add everolimus to exemestane after failure of non-steroidal aromatase inhibitors. Now we go to the Cdk4 Six Inhibitors. You have heard a lot about them over the last 2 days. A summary of the trials in postmenopausal women. Here we have the Paloma 1 and Paloma 2 palbociclib with letrozole, and then we had the Mona Lisa 2 that added ribociclib to letrozole, and the Monarch 3 that added abemaciclib to any non-steroidal aromatase inhibitor. We had 14 versus 24 months, 13 versus 23 months. So we have a 10 months improvement with the addition of Cdk4 Six Inhibitors. This is very important. Median progression-free survival. You're talking 2 years. Now, we just had the results of the Mona Lisa 7 in pre-menopausal women. Again, significant improvement from 13 to 23 months. This is a summary of the, this was presented by Nancy Lin at San Antonio, like a summary of all the FDA approvals. The 3 agents are now approved in the US. So the ABC4 guidelines, we stated that the addition of a Cdk4 Six inhibitor to an AI in patients naive or pre-exposed to endocrine therapy provides significant improvement in median progression-free survival, about 10 months, and an acceptable toxicity profile, therefore is one of the preferred options, treatment options. We mentioned again that patients relapsing less than 12 months after the end of adjuvant aromatase inhibitor were not included in the published studies and may not be suitable for this combination. The addition of a Cdk4 Six inhibitor to fulvestrant in patients who were previously exposed to endocrine therapy, as in Paloma 3, as you heard it, and the also Monarch study, we have an improvement of 6 to 7 months in progression-free survival, and it is one of the preferred treatment options if a Cdk4 Six inhibitor was not previously used before. Now, the optimal sequencing, we've discussed it over and over. It is uncertain what is the optimal sequencing. We can do aromatase inhibitor, tamoxifen, fulvestrant. The thing is, if the patient relapses, we have fulvestrant, we have Cdk4 Six inhibitor, everolimus, even megestrol acetate and estradiol may be used. We still do not know what is the optimal sequence. An important statement is that everolimus and Cdk4 Six inhibitors should not be used after disease progression on that specific agent. So we do not have data for beyond progression, like we do with trastuzumab, for instance. They should not be used beyond progression. Now, when we have a patient who is premenopausal, we have the NCCN guidelines, and all we do, we recommend premenopausal women, we do ovarian ablation or suppression, and then we proceed with endocrine therapy like postmenopausal women. And we have a confirmatory trial, the Mona Lisa 7, that shows that when you add ribociclib, either tamoxifen or aromatase inhibitor, after ovarian function suppression, you get the same benefit, 10 months improvement. So we had an important statement at ABC4 that took about half an hour, Javier, right? You remember? That was the first statement we had. Many trials in ER positive ABC advanced breast cancer, they do not usually include premenopausal women. So this is why we always recommend, right, young women with ER positive, we should have adequate ovarian suppression or ablation, and then treat in the same way as postmenopausal women. And 95% of the panel agreed on this. So we had a statement, this statement, that future trial, we recommend that exploring new endocrine-based strategies should be designed to allow premenopausal women to be included in those trials. Very important not to always keep waiting. In postmenopausal, will then extrapolate to premenopausal women. Now, with this comes another important statement, the definition of adequate ovarian suppression. The adequate ovarian suppression can be obtained through bilateral oophorectomy, continuous use of GnRH analog, or ovarian function ablation by radiation therapy. The majority of the panel agrees that, it is less effective when you do radiotherapy. Now, if a GnRH analog LHRH agonist is used in this age group, it should be given every 4 weeks. We do not recommend the every 3 months because you may not always have adequate suppression throughout. So we should use it every 4 weeks to optimize ovarian function suppression, and maybe also important to evaluate serum estradiol levels. Even if the patient has amenorrhea and you're giving aromatase inhibitor, especially in very young women, you may not have adequate suppression. It's important to monitor them. Okay, now a few statements on HER2 positive patients. If you decide to give hormonal therapy, usually recommendation chemotherapy with trastuzumab and pertuzumab, that was discussed. If you decide to do hormonal therapy, the panel agreed, 80% of the panel agreed that dual anti-HER2 blockade with either pertuzumab, trastuzumab, or lapatinib, trastuzumab can be used because it provides benefit in progression-free survival. Of course, this has to be balanced against toxicity and also higher costs as well. Now, for patients whom were given chemotherapy with anti-HER2, it is reasonable to use endocrine therapy plus anti-HER2 as maintenance therapy after we stop chemotherapy. We do that most of the time. Now, the duration of maintenance therapy, it should be until progression. This is what we know. We don't know if we have to stop it. Either disease progression or unacceptable toxicity or patient requests. And this should be evaluated in clinical trials. Now, about PARP inhibitors, the 80% of the panel agreed, and we just heard Dr. Banu. PARP inhibitor olaparib is a reasonable option for patients with BRCA-associated triple-negative or luminal after progression on endocrine therapy, of course, previously treated with an anthracycline with or without a taxane because it provided progression-free survival benefit and improvement in the quality of life and has a favorable toxicity profile. Overall survival are awaited. This is really based on the Olympian trial that we just heard about it. And of course, at the ABC4, we did not address talazoparib. We just spoke about olaparib because we had the data. One of the last slides I have, biosimilars. Hope Rugo was here. I don't know if she's in this room. Now we had a long discussion. ABC community strongly supports the use of biosimilars both for the treatment of breast cancer, trastuzumab, and supportive care growth factors. To be used, the biosimilar must be approved after passing stringent development and validation processes required by the European EMA and the American FDA or other similar strict authority. It really has to be a strict authority. And in the manuscript, we agreed that we will say that the use of biosimilar can only lead to a significant economic impact if the price of biosimilars is substantially lower. يلا معلش اعطيني دقيقة اعمل معروف. يلا شيلها هيدي شيلها أنا. All right. So very important that we need to have substantially lower prices than the patented original drug. Based, of course, this is the heritage study that Hope had presented showing similar results with trastuzumab or the biosimilar. Precision medicine, multigene panels should not be used in routine clinical practice. Immunotherapy should not be used in clinical routine practice outside of clinical trials. At another point, we discussed the supportive care, very important to discuss with the patient, instruct, try to prevent toxicities, hand-foot syndrome, skin care, very important, steroid mouthwash, mild toothpaste, gentle hygiene. It's really important to pay attention to those details, and using steroid dental paste, delaying treatment until toxicity is resolved. These are very important. I invite you for the November 2019 ABC5, and thank you very much.
Thank you very much, Professor Saghir, for this excellent presentation that summarized the yesterday and the today morning session. And now there is time for only one or two questions. Mike here, please. Mike. Fish Mike. طب قولي حضرتك نعم اتفضل اتفضلي دكتور مروان يزيد.
For patients with inflammatory breast cancer with concurrent de novo asymptomatic visceral metastasis. Inflammatory with concurrent metastatic disease, but not in visceral crisis. If the patient is hormone receptor positive, HER2 negative, do we have to follow the guidelines for the hormone receptor HER2 negative guidelines by giving her hormonal therapy plus or minus Cdk4 Six Inhibitors if affordable? Or we are allowed to give her chemotherapy because she has a rapidly progressive disease, and we know that hormonal therapy will show response in a longer period of time. No, metastatic with concurrent asymptomatic metastasis. Hormone receptor positive, HER2 negative.
I said in the guideline, thank you very much for your question. I said in the guideline that the only difference in the guidelines is for the surgery approach of those patients, and that you cannot perform local control or minimal surgery, and you cannot perform sentinel lymph node dissection. In all the parts of the guidelines for inflammatory breast cancer, you have the same recommendations as classical non-inflammatory breast cancer. We know that there might be more resistance, but you need to go and to stick to the definitions. If you have a visceral crisis, you need to go to chemotherapy. If you don't have visceral crisis and the patient is obviously hormone positive, this is the minority of these patients. But if they are in this subcategory of hormone receptor positive patients, you need to give them the chance to respond to hormonal treatment. So you need to do it like other patients. They will most probably they will not respond, maybe very rapidly, but you need to give them this chance.
Thank you very much. Now we reach the end of the session, and Many thanks to the presenter, Professor Banu, Professor Marwan Ghost, Professor Hassan Ghaffar, Professor Nahad Ibrahim, and Professor Saza German, and Professor Nagi Saghir. And thank you very much for my co-chair and for the audience, and see you next week.